Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient who becomes weak after a major hypotensive episode, perhaps after sepsis, surgery, myocardial infarction, arrhythmia, dehydration, or cardiac arrest. The CT may initially be unrevealing, but the MRI later shows infarcts not in one neat arterial territory, but in the border zones between territories. That pattern should make you think of hypoperfusion stroke. Hypoperfusion stroke means ischemic stroke caused by critically reduced cerebral blood flow. The key idea is not simply a blocked small artery, but failure of perfusion. This usually happens because of systemic hypotension, shock, cardiac arrest, or severe proximal arterial stenosis, especially severe carotid, internal carotid artery, or intracranial stenosis. To understand this topic, think in 4 boxes: the trigger, the vulnerable area, the clinical pattern, and the management principle. First, the trigger. Cerebral perfusion pressure falls when systemic blood pressure drops, or when a major upstream vessel is severely narrowed or occluded. Normally, the brain protects itself by autoregulation. Arterioles dilate to maintain cerebral blood flow despite a fall in perfusion pressure. But once autoregulation is exhausted, cerebral blood flow falls. Reduced flow leads to ATP depletion. ATP depletion leads to sodium-potassium pump failure. Pump failure leads to cytotoxic edema. If perfusion is not restored, this becomes infarction. The most vulnerable areas are the watershed zones. These are the border areas between major arterial supplies. Cortical watershed zones lie between the anterior cerebral artery and middle cerebral artery territories, and between the middle cerebral artery and posterior cerebral artery territories. Internal, or deep, watershed zones lie between the superficial cortical supply and the deep perforator systems. These regions are at the far end of arterial supply, so when pressure drops, they are the first to suffer. Now look carefully at the MRI image. The important feature is the abnormal signal change in the watershed regions, especially in the bilateral border zone areas. This pattern is not confined to a single arterial territory, such as one complete middle cerebral artery infarct. Instead, the changes are patchy and bilateral, involving the distal border zones. Depending on the MRI sequence, infarcted or ischemic tissue may appear as abnormal hyperintensity or hypointensity, but the key exam point is the distribution. The distribution tells you the mechanism. Bilateral border zone involvement strongly supports hypoperfusion, particularly when the history includes hypotension, shock, cardiac arrest, or severe carotid stenosis. The image is not just showing a stroke. It is showing a hemodynamic pattern of stroke. The distal end zones are affected first because they are furthest from the main arterial supply. When perfusion pressure falls, these areas receive the least reserve flow. That is why watershed infarcts are sometimes called the radiological fingerprint of impaired cerebral perfusion. Clinically, the story often gives the diagnosis. The patient may deteriorate after shock, sepsis, arrhythmia, myocardial infarction, dehydration, or surgery. A very classic exam clue is bilateral proximal limb weakness, sometimes called man-in-the-barrel syndrome. The patient may have difficulty lifting the arms and sometimes the proximal legs because the anterior cerebral artery to middle cerebral artery watershed area involves shoulder and hip motor regions. Cortical watershed infarcts can also produce aphasia, neglect, or visual symptoms, depending on the hemisphere and the border zone involved. Internal watershed infarcts often cause weakness that may fluctuate or progress because the deep white matter is highly vulnerable to low perfusion. A useful clinical clue is hemodynamic dependence. Symptoms worsen when the patient sits or stands up, or when blood pressure is lowered too aggressively. Do not confuse this with a single embolic territorial stroke. A large embolus usually produces a vascular territory pattern, such as a complete middle cerebral artery syndrome. Hypoperfusion stroke often produces bilateral, linear, or patchy infarcts in watershed regions. However, MRCP trap mechanisms can be mixed. Severe carotid disease and hypotension can cause distal field ischemia, but emboli from the same diseased artery may also coexist. Diagnosis depends on matching the history with the imaging. MRI with diffusion-weighted imaging is the most useful test in acute ischemia. It may show linear or patchy infarcts in watershed distributions, sometimes bilateral. Vascular imaging is essential. CT angiography, MR angiography, or carotid duplex can identify carotid stenosis, internal carotid artery occlusion, or intracranial stenosis. Perfusion imaging can strengthen the diagnosis. You may see prolonged mean transit time or increased Tmax with reduced cerebral blood flow. Cerebral blood volume may be preserved in penumbra but reduced in established infarction. In other words, delayed flow with salvageable tissue suggests threatened perfusion, while low flow with low volume suggests infarcted tissue. The investigation is not complete unless you look for the trigger. Review the blood pressure record. Check ECG and telemetry for arrhythmia. Consider echocardiography after myocardial infarction or suspected cardiac source. Look for sepsis, bleeding, dehydration, or any cause of systemic hypotension. The diagnosis is a combination of event, vessel, and imaging pattern. Management starts with a simple principle: restore perfusion and avoid making hypoperfusion worse. In the acute setting, correct hypotension. Give fluids if volume depleted. Use vasopressors if needed in shock. Avoid aggressive blood pressure reduction, especially in a patient with hemodynamically dependent, severe carotid or intracranial stenosis. At the same time, treat it as an ischemic stroke. Use standard acute stroke pathways. Thrombolysis or thrombectomy is not automatically indicated just because there is infarction. It is only considered if the patient meets eligibility criteria and there is an occlusive thromboembolic mechanism where reperfusion therapy is appropriate. Secondary prevention includes antiplatelet therapy, high-intensity statin therapy where appropriate, and control of vascular risk factors such as hypertension, diabetes, smoking, and atrial fibrillation if present. But the exam point is this: in hemodynamic stroke, overlowering blood pressure can worsen symptoms. Blood pressure targets must be individualized, especially when severe proximal stenosis is present. For severe symptomatic carotid stenosis, carotid endarterectomy or stenting may be appropriate, depending on anatomy, timing, operative risk, and local specialist assessment. The aim is to prevent further embolic and hemodynamic events. In patients with intracranial stenosis, management usually centers on intensive medical therapy and careful risk factor control. If you remember one thing, remember this: watershed infarcts are the imaging clue to impaired perfusion. When you see bilateral border zone abnormalities, ask what reduced the pressure and ask whether there is severe proximal stenosis. MRCP trap: do not call every watershed infarct purely hypotensive. Severe carotid disease, systemic hypotension, and artery-to-artery embolism can overlap. The safest exam approach is to identify the pattern, find the trigger, image the vessels, and avoid aggressive blood pressure lowering while perfusion is threatened. Do subscribe to the channel for further videos.